Taylor, it's 7:05. Why don't we take it away?
Hi, everyone. Welcome to tonight's virtual shadowing session. My name is Taylor, and tonight we'll be talking about pediatric emergency medicine with Dr. Pam Okada. But before we get started, I just wanted to reintroduce the team and thank everyone, and then announce a couple sessions. So as of course, we have Rachel, Reagan, Shayon, Ani, Miriam, Alana, and myself. And then next week, we're going to be talking about acute trauma care. And then the week after that, we're going to talk about physicians and finance. So that being said, I'm going to let Dr. Fowler take it away.
Well, welcome everybody. And this evening, I'm speaking to you from the hills of Western Georgia. Go Georgia, go Atlanta, go Dogs. I want to remind everybody that this is our 11th session. We're so delighted to have our guest, whom I'll introduce in just a moment. We have put out a GoFundMe page, and if you could give us $1 or $2, for those that have given a little bit more, that'd be great. Our true real costs with a Zoom account of $1,000 and with our MailChimp account, those things add up to several $1,000s. We've already collected a couple thousand. We'd appreciate it very much if you would check the GoFundMe thing. That would be very nice of you. As we're now approaching 1,500 folks live online, allow me to introduce someone that I think is an absolutely astonishing individual that I've known for years. Pam Okada is board certified in pediatrics and pediatric emergency medicine. She received her medical degree from Tulane University School of Medicine in 1990 and completed her pediatric residency at Harbor UCLA Medical School and her pediatric emergency medicine fellowship at my alma mater here, UT Southwestern Medical Center in Dallas. In 2016, Dr. Okada completed her Master's of Science in Clinical Science at UT Southwestern Medical Center at Dallas and completed a certificate for the Alliance of Medical Management Education at the University of Texas at Dallas. She is currently also deciding that she hasn't been in school long enough, working on her Master's in Business Administration. She is one of the kindest, most notable, widely sought out speakers and humanitarians that I have ever had the pleasure to meet. Would you please all throw into the chat a welcome, Dr. Okada. Welcome, Dr. Okada. Pam, take it away.
Thank you, Dr. Fowler. Taylor, thank you guys for setting all this up. I wish we could all be together as we talk about something that I am very passionate about, and that's pediatrics, pediatric emergency medicine. It is a great field, and it's a field where you can really make a difference. Okay? You're making differences in a child's life really early in their life, and it really pertains to the rest of their adulthood, right? If you can imagine all the children that you guys know, and your nieces and nephews, maybe your brothers and sisters, people that you really can, you watch them grow up and you notice how just a few words of kindness, you can make a difference in their life. Can you imagine that they come to the emergency department scared for their parents? It's their worst day of their life, and it's you at the door. Okay, and I know I saw on the chat already, Lola, right? You're going to be a pediatric emergency medicine doctor. There's a whole bunch of you guys who said, yeah, I want to do peds. And it's a very worthwhile endeavor. I'm going to go ahead and try and move my slides here. All right. Well, what is it? I'm going to introduce you to the field of my life. Okay. These are pictures from a crash that occurred where a semi and a little car collided on the freeway here in Dallas, Texas. This is a 6-month-old baby who mom put in a car seat, thank goodness. And here she is there. And we are doing what we call a trauma resuscitation. So this is my life every day. And I want you to know that it is more than just taking care of the medical part, right? Making sure that broken bones can be mended and that the babies can breathe. But as you can see, our job is to take care of the mom, to comfort her during the worst day of her life. It's working as a team. All these people work together to help these children. Here's another mom. After her son, they were building in their home and the railing wasn't built. but he decided to go off the second floor onto concrete. And again, he is at risk for hurting his spine, his head, internal organs. And so we have to look at him, developmentally assess him, see what his injuries are, but also explain to him in the words that he understands how we can take care of him, how we're going to make him better, how he can hopefully soon go home with mommy. But again, it's all about the family. You see how we're here, we're helping the mom process through the worst day of her life. And it's not just one person, we're dealing with the whole family unit. And it's not just one person taking care of the child, it's a whole team. And so I know that some of you guys out there on listening, you want to go into PA school. We depend on you. You want to be a radiologist or radiation technologist. You want to be a respiratory therapist. All of y'all work together to help wholeness to a family. So what is it? You have to decide, is pediatrics and pediatric emergency medicine for me? Some of these pictures are graphic. They're all on the internet. They are injuries of children that are very similar to what we've seen and taken care of. Actually, these pictures are from the ED where I work. Pediatric emergency medicine, we see kids up into age 18, sometimes 21. It is a very high-paced environment where children come in through the front door while they're waiting. Some kids come in through the ambulance. Some kids are flown in by helicopter or fixed wing. And some kids are actually in the hospital playing, and then they get injured while they're waiting or waiting for their brother or sister. So it is high paced. We never know what's going to come through the door. The interesting thing, the reason why it's so appealing is that there's a wide spectrum of diseases and problems that present to you. This picture is a child, okay, they're outside with dad while he's mowing the lawn, and dad forgets that the mower on the tractor, here in Texas, we have big mowers and big tractors, kind of sweeps around and makes a big circle, right? And the toddler was right there, and his foot got into the tractor of the mowing lawn. And so he sustained open fractures or broken bones to his foot with tendon and joint involvement. And these are some of the things that we have to assess, diagnose, and then get consults so that we can help the child regain function of this foot again. So we call orthopedic specialists to come down and help us. Sometimes we call surgeons. We call different specialists to come assist us. And so it's a teamwork environment. And a lot of times we're dealing with life and death situations. Here in Texas, there's lots of water injuries, right? When kids are out on lifeboat boats in our lakes, they get injured there. We have kids ride horses and sheep, and sometimes they're not doing what they're supposed to be doing. They get injured. And then a lot of the things we deal with are just plain accidents. And parents didn't know that their screen wasn't working, and the child wanted to say bye to dad as he's walking to work and pushes out the screen and falls out the second story window. These things happen and they're accidents. And so that's what we get to do, is help families and meet them at their worst times of their lives in the ER. The other thing is, it allows you, if you love to teach, and I know a lot of you guys out there love to advocate for people. I saw that on the chat last week. You love to educate people. And it's sometimes a really good time for us to teach and help inform families on how to take care of their son or their daughter. And those moments, they're very appreciative, because a lot of times they just didn't know. And so we have and work in a really high impact environment where you can make a difference, whether it's as a respiratory therapist, as a PA, as a nurse practitioner, as a doctor, as a pharmacist. We even have pharmacists work in the emergency department. It's an environment where we all get together and help meet the needs of a child. So what are some things that I see regularly? Well, kids here, construction, we have those hammer guns, and children get their finger stuck with the nails. This is actually a pretty minor injury. It looks terrible, but it's easily fixable. What does that look like to somebody? Does that look normal? No, it is. It looks like she has an extra joint right here, right? In this kind of Y-shaped, U-shaped area. This is her wrist. That's normal. This is her elbow. Looks pretty normal. It looks like she has an extra elbow right here where my arrow is. That is probably a broken bone, right? We call this a both bone forearm fracture because both the radius and the ulna are broken together. The good thing is easily fixable. Asthma. Who out there has asthma? You've had an asthma attack, something triggers an allergic reaction or an asthma attack and you need breathing treatments. This is probably one of the most common chronic illnesses that we see in children. It's worldwide increasing, especially in the United States. We don't know why, but asthma is something that we see daily, especially when school starts. So in a couple of weeks, when kids start going back to school, we're going to see an uptick in patients with asthma exacerbations. Dog bites. I don't know if y'all have dogs, but some breeds of dogs, they get very jealous and protective over their food. And we do have a lot of children who come in with dog bites and dog maulings. And so these are all accidents. But you know, I don't know if any of you guys know young babies, but they can't talk, right? They're cute, but then at 2 a.m, something triggers and they're crying. And they come to the emergency department because they're fussy. We see a fussy infant regularly, or more acutely, an emergency, they have trouble breathing because maybe RSV bronchiolitis, which is an inflammatory disease that's caused by a winter virus, or a fever. And these can be life-threatening to babies, but it's also fun for us because we get to play with the cute little babies. What are some of the benefits of pediatrics and pediatric emergency medicine? Well, as I've already alluded to, you have the unique ability to help people. And you see a wide spectrum of illnesses from not too sick, maybe just worried, to really, really sick. But in every instance, with a great perspective, you're able to help people. Every day is different. And right now with COVID, every day is definitely different. It's new and exciting. Things change every day. We don't know if school's going to create more visits to the emergency department because children, they may try to keep on a mask, but as you know, children like to play and put their hands in their mouth and share things. They're also very close proximity, so they're going to be sharing germs. And so it's fun and exciting. We never know how the day's going to be, depending on what's going on in the environment. We have fun procedures. You guys know what this is? This thing right here is a metal detector. It's a very simple object that you can buy at Home Depot, right? We actually use this in the emergency department. Kids, for some reason, who knows what this is? Put that in the chat if you know. It's round. It's what we call radio opaque, and it's stuck right in the neck area. Now I'll describe what we see here. This is a baby. His hands are up, and that's how we take x-rays of little baby's chest. This is his clavicle bones, or his collarbones. This is his heart, lungs here, stomach bubble, so he has gas, probably crying, a gas bubble. And then this side is the diaphragm and the liver. This is the liver. So this is not normal. We normally don't have this kind of bright, shiny thing stuck in the middle of our throat. Well, it's a quarter. The child decided to, kids put things in their mouths always, their hands, toys, money. They think they're slot machines, and the quarter is so big that it can't actually go down into the esophagus. So it gets stuck right here between the clavicles. A lot of times, the best way to see where it is is to get a chest x-ray. But if you're not really sure where it is, you can get out your handy dandy wand here, your metal detector, and wand it up and down the child and go dee, 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 and you can find out where it is. And this allows you to x-ray the appropriate place instead of x-raying the baby's whole, chest and tummy, because x-rays are not benign, meaning they do give children radiation, and you don't want to radiate a baby unnecessarily. So we have fun gadgets that we use, and I'm going to show you a few more gadgets that we use to help save lives. I work shifts. Anybody know what that is? It's I don't work 24 or 36 hours. I work shifts. So that means I may do 3 days on, 9-hour shifts, and I'll have 2 or 3 days off to catch up and do academic work. But I know my start and my end of my day. I go in at 6 a.m. and I leave at between 3 and 4 p.m. Or I go in at 2 p.m. and I leave around midnight. And the benefit of shift work for me was that I also wanted to have a large family. And so shift work allowed me to juggle both. And during the time when my children were young, I would do shift work, meaning I'd work overnight while they were all sleeping. They thought I was sleeping. I would go to work, come home, feed them, get them ready for school. They'd go to school, and then I'd go take a nap in the closet. And that way I can be up and ready and participate when they got home from school. So shift work was amazing blessing for me because it allowed me to manage a large family. And it also allowed me to go shopping or go to the dentist or do other important things for my children when other parents are working, or other docs are working, say, in the office 8 to 5 or 8 to 6. I needed that flexibility because I'm ADHD and I needed to be able to just go and do a whole bunch of different things. And then again, it's intellectually stimulating because with the broadness of the types of diseases and injuries and things that come to the emergency department, you kind of gotta know a lot of different things. And now with technology, all right, we have technology dependent children. Maybe they have to breathe through a tube. Maybe they need feeding through a button that goes into their tummy because they can't suck, swallow, and digest food normally. Maybe we have kids who had a bone marrow transplant after conquering leukemia. You have to know a whole bunch of different things. You have to especially know all the medications that are constantly changing and being developed. So it's intellectually stimulating. If you guys have any questions, please feel free to put them into the chat. The gang, Taylor and Reagan and Ani and all these guys, they're on watching the chat and they will be bringing up questions that you have, especially if I talk too fast, because sometimes I get excited and I ramble. What are some of the difficulties, the downside to pediatric emergency medicine? Well, it is stressful. When you're working, you work. You don't get to sleep. I mean, Dr. Fowler knows, and we go and you can't stop going because you have to be ready for every emergency that comes through your door. Right now with COVID, it's even harder because we don't, as emergency medicine docs, we don't leave the ER, go put our feet up and have lunch. No, we keep working through that. And now with COVID, we can't even take off our masks, right? And eat because it exposes us to COVID. And so it puts us at different risks. So we're supposed to be wearing our N95s throughout the whole shift without taking off our mask. And so it is stressful, especially if you get really hungry. The other thing is we work in volume. So my patients don't schedule their visit to the ER, right? I don't say, oh, I have 20 patients before 12 noon. No, I have patients that come when they have an emergency. They come whether we have enough beds in the hospital or in the emergency department or not. They keep coming. With the high turnover, it means I have a lot of paperwork. We don't use paper anymore. 25 years ago, we wrote everything, all the medical records on paper. And now we use electronic medical records. But we still have to account for every encounter, every medication, every complaint that a family has. We have to fill out a medical record so that if the patient comes back again, or if the patient needs a referral, the specialist who receives our patient will know what we did for them in the emergency department. So it's high turnover, lots of charting in the medical record, and it's constant. Liability is another thing that we worry about and have to deal with here in the United States. Liability occurs mostly in emergency medicine is because we do not have a lot of relationship with the families. We don't know the families, right? It could be the first time that they come to our ER. And without that relationship, we are more likely to get sued if we make a mistake or if they're unhappy. And so liability is one thing that we do need to worry about. We also work nights and weekends and even the holidays. So I work, right now I work mostly weekends because it's convenient, and then I could do other things like go to school during the week. But holidays, right? We all have to divide up the holidays evenly. Christmas, I work Christmas one year, and then and New Year's, and then the next year I may work all the minor holidays and Thanksgiving. We all share the responsibility because the emergency department is open 24/7, even 3 in the morning on Christmas. You need to be open and available. And then another downside is that, sometimes children do die, okay? And it is really sad when they pass away. It could be from a car crash. It could be from infection. It could be because of child abuse. And a lot of these times when you see a baby dying or, you see the parents mourning, you feel really bad and you cry and you deal with that. You have to deal with that when you go home and figure out how you're going to manage the burden of a death that happened on your shift. And so it's life and death, and it's real. Right now, also, the new thing with technology is that there's so much information available. If you're a detail-oriented person, you can get sucked up into looking at every detail to help your patient when they just came in for a hangnail, right? And you have to be able to separate yourself from all the detail to be able to meet the needs of what they need at that moment in time. But again, as science and AI develop over the next 10, 15 years, you guys, you're the next generation of doctors. You're going to have to deal with all this information sharing and be able to figure out what's real and what's not real, right? Because even I'm telling you right now with this COVID, knowing what articles out there based on science or fabricated, what is applicable to children in the United States versus in other countries. Is it applicable? Is it generalizable? Or is it fake? Is it made up? Is it fabricated? And so with time, we're all going to have to be able to deal with the excess and the amount of information that we need to process through to take care of children. Well, what I know all you guys are wondering, how do you get to pediatric emergency medicine and the journey? And so I'll tell you my journey. And because I'm going to kind of go way back because I see a lot of people from Canada. Welcome to this. I'm really excited. I'm Canadian. My parents were born and raised in Canada, and they immigrated to the United States many years ago. And I grew up in California. So I know there are a lot of Californians online. I went to UCLA. I went on a scholarship because my parents couldn't afford college for me. And the only way I was able to go was to apply for a scholarship. And fortunately, I was blessed with this scholarship to go to UCLA. For all of y'all looking into medicine, you can choose, and all of you guys know this, I'm sure you've already researched this and your mentors are telling you, you can be any major, right? And it's great to be something totally different, be a theater major or be a sociology major, be a writer, and then take pre-med classes. And there's very set form of all the pre-med classes, the requirements that you need to have done well in and prepared to be able to, one, sit for the MCATs, which is a really great test, so fun. I know some of you guys have already done this and are working towards that now. And then to be able to apply for medical school. You take any major, and that is one thing that I thought about. You know, people ask, would I have done anything differently? And I think the one thing that I would have relished in and should have concentrated more on is writing during college. Because guess what? When you become a physician, especially in academic medicine, you do need to know how to write well and to be able to express your thoughts both verbally and then in written form. And so I encourage you to take writing classes. And then you take that MCAT and you do great, right? And you go to medical school. So medical schools around the country, there's both MD and DO schools. And during that time, it's 4 years of hard work, but you get exposed to a lot of different aspects of medicine. And you'll be exposed to pediatrics on your rotations in peds, both inpatient, outpatient. You'll be exposed to radiology, ophthalmology, surgery, psychology, neurology, whole bunch of stuff. And that's how you then decide, oh, I really love the eyeball, or, oh, I really love kids. And I always knew that I really, really love kids because ever since I was in 4th grade, I wanted to take care of kids, be a pediatrician and cure something. Like I really wanted to cure cancer, leukemia, but I decided to take a different path when I did internship and residency. And so during my internship and residency, I decided to do pediatrics. But I want you guys to know that for pediatric emergency medicine, there are 2 routes to get to the end game, right? You can be a pediatric resident, intern and resident, or you can be general emergency medicine. And then after you finish your internship and residency, you can do your fellowship in pediatric emergency medicine. So I decided to do pediatrics and then do pediatric emergency medicine fellowship after that. I chose pediatrics because I love children. They smell good. They're really cute. And I wanted to have, I know some of you guys were on last week, I wanted to have 12 kids. And so I needed a profession where I could balance both home life and work life. And that's why, and both of them, it made sense, right? Meshed together. And you'd be surprised. I had a kid during internship. So I got, when I graduated from medical school, I had a baby right before I started internship, which I don't really recommend. It was super hard. But from a pediatrician standpoint, boy, the people I work with, they got it. They understood the things that I had to juggle. They also understood when I needed to go take my child to the doctor. They understood when I had questions about breastfeeding. They supported me through that whole time. And I chose Harbor UCLA specifically because the department chair at that time really understood the desires of my heart to be able to balance medicine and my job, my profession. So that's why I chose Harbor UCLA. The other neat thing though is when people ask, well, Would you do anything differently? I thought about this. Would I do emergency medicine first and do PGM after? I need a lot of you guys to think about both of these ways because, you know, Fowler and Morchetti can tell you that emergency medicine is great because you could take care of the whole spectrum of patients from 0 up to 100 or 100 plus years, right? So there's no limit on your knowledge. And I think maybe if I had thought about it, maybe a little bit more, maybe didn't want 12 children, I might have chosen the path of adult emergency medicine or general emergency medicine first. But I have no regrets. I loved my pediatric training because I got to play with kids pretty much for 3 years. Anybody have any questions regarding the path that I took and the journey?
So Pam, you're saying that there are a couple of ways then to approach emergency medicine for pediatrics. You could either do emergency medicine first as a residency, typically 3 or 4 years, and then do pediatrics after that. Or you could become a pediatrician and then do an emergency medicine residency after that. Could you cover that one more time? Because we're getting a lot of questions about that.
Sure. I'm sorry if I wasn't clear. There are two like rivers to get to the end stream, to the end ocean. You can do pediatrics or you can do general emergency medicine. And then both allow you to apply for a fellowship in pediatric emergency medicine. And so you can come at it both ways. And Dr. Marianne Gaucher, all of us know, Ray and Dr. Fowler and Dr. Marchetti know, she trained at Harbor UCLA, and she was actually one of my mentors during my internship and residency. And she did general emergency medicine first, and then was one of the pioneers to be trained as pediatric emergency medicine afterwards. And she did a lot of research in both general emergency medicine and pediatrics, and really has made herself known as one of the founders of pediatric emergency medicine. So you can come at it from both ways. Some of the people have been asking about my undergrad major, and that was, I just did biology because I didn't know what the heck I was doing, all right? My parents didn't go to college in the United States. And so when I applied to college, I didn't even know if I could go because we couldn't afford school. And it wasn't until I got the scholarship that I was able to go to UCLA. And there I just did straight biology because I love sciences. And we didn't have computers back then. So there wasn't anything digital or computer that I could major in as well.
So what's the major difference then between emergency medicine pediatrics versus pediatrics alone? Is it a shift work thing or a high intensity work environment? Don't pediatrics in their office see really sick kids sometimes?
Oh, that's a great point. Okay, so pediatrics, or what we call outpatient pediatrics or general pediatrics, you do 3 years, your internship and residency. You get to do rotations in the emergency department, but most of your training is to give you a broad exposure to bread and butter, what we call bread and butter pediatrics. So vaccines and growth and development, overall health, behavioral health, just kind of general pediatrics. And then you go into the community. I know all of you guys have your own family doctor or your pediatrician. You go into the community and you take care of patients in the community. Now, I tell you, you need to be prepared to take care of an emergency like an asthma attack, or we've had kids go to the pediatrician's office for a fever and then they'll have a seizure and stop breathing. So you do need to have basic information and understanding how to resuscitate or help a baby when they're having a seizure or not breathing. But then you call 911 and EMS comes and then brings them to the emergency department. So it is kind of the acuity. You see more lower acuity patients in general pediatrics, and then pediatric emergency medicine, you're seeing more of the high energy, high kind of more acute kind of injuries in the emergency department.
Is there any particular type you see the most of that are quite sick in the ER for PEDS-EM? Is it babies? Is it young kids? Is it teenagers? Or does it just vary from day to day?
It varies from day to day, and I'll show you some more pictures of different things. And it's also very seasonal. You'd be surprised during the winter. We see more younger children, infants and school-age children, because they're exposing each other to viruses. And so they come into the emergency department because of breathing difficulty or fever. And then during the summer, it's more toddlers, teenagers, because they're getting into accidents. They're outside playing, they'll ride their ATV and roll it over. They'll be playing, doing crazy things, jumping off of roofs and breaking their legs. So it just kind of depends on the season.
So Pam, what personality traits are important for success in becoming a pediatrician? Is there something special, something different that's not on a radiologist, it's not a neurologist, it's a pediatrician?
I think you really have to love children and want to get down to their level and to get into their brain. And some of us are naturally like that because we're a bunch of big kids. But I think it really, you just have to love children and be okay with crying, be okay with them not being able to explain things to you, because that's part of pediatrics. You have to be really, really patient and empathetic, because guess what? You're not only dealing with the moms, the babies, you're dealing with the moms and the dads or the guardians, the aunties and the uncles.
So you clearly have a very loving, soft, warm personality. Have you ever found that by being in pediatrics, especially around terribly sick children, that you've ever personally been traumatized by an event like that? And by that, I mean emotionally, of course.
Emotionally, yeah. I think back over all these years, and there are children that you will never forget. And one of them, my first death, actually, as an intern, a mom had a baby, and the baby was suffering. Okay, it's called fetal distress, and the baby's heart tones were failing within the womb. And what happens is when babies are stressed out before they're born, they have this thing called meconium, and they pretty much poop within the womb. And when they're being born, this baby had such bad distress that his heart started failing, and he was born a large 8-pound, he was 8 pounds, covered in his own stool, and that's called meconium, and he had died. And that baby, I just remember the mom rocking him in her arms and crying. And I just had, I told you, I just had a baby myself, and I will never forget that. And it broke my heart. I actually had to go into the hallway stairs and I just cried because it was so devastating to see this mom mourning over a baby that looked perfectly fine, except for he wasn't breathing. So there are lots of other instances throughout my career that I can remember that really bothered me and hurt me. And a lot of them surround child abuse, because child abuse has been prevalent, unfortunately, in our society. And it's not the baby's fault, right? And they come in either with broken bones or head injured or just very ill. Somebody asked about neonatology, and I'm not a neonatologist, but as a neonatologist, you do have to do a fellowship. So you do 3 years of pediatrics, and then you do neonatology following that. And Dr. Fowler, if you want me to hook you up with a neonatologist to share their experiences as neonatology, I have a fabulous friend
We would
who
love that, ma'am. We would love that.
hilarious. You would love her. And she'd be able to tell you, you take care of the little babies after they've been born, right around the birthing time. And so they're usually under 28 days that you're taking care of them in the NICU. And it's a high intensity, critical care environment as well.
So, if you survey any part of the medical profession, you find that a very substantial portion of physicians, nurses, techs, and so forth are burned out. Emergency medicine, especially also EMS, has been said to have a high burnout rate. Are you burned out, Pam? And if so, why not? How do you keep finding that water in the well?
I love that question. I just gave a burnout lecture to pediatric emergency medicine fellows at a conference in February, right before COVID. And and I had to sit back and think about my career and where I am and if I was burnt out or not. And I am not burnt out. I have a problem though with saying yes. I do not know how to say no. And so I may overextend myself because I want to help, and that's my personality. And so I always say yes, and sometimes overextend myself, and then I don't do as good a job at helping somebody succeed or helping them with a project or finishing something in a timely manner. But the one thing that I can recommend, there's this famous author who writes about 10%. To keep from burning out, there's been some studies that show that if you're doing something, whatever that is, right, in school or in work, or for us in healthcare and medicine, as long as you're balancing your daily ins and outs with 10% of not something that makes you so happy, that you will keep yourself from being burnt out. And that 10% for me, right? I've worked at UT Southwestern for a little while, and I have to do a lot of administrative stuff. I'm telling you that administrative stuff is not my happy 10%. It is taking care of the patient. I love being in the ED, sitting on the floor with my 3-year-old patient, trying to figure out why they're limping, okay, or talking to a new mom who's crying because her little 7-day-old won't poop. I love being in the ER. And so I think that's my happy 10%. Well, I know that's my happy 10%. And so as long as I'm fulfilling my day, my week with that at least 10% of clinical work, I maintain the energy to keep going and doing the other stuff that might not be so fun.
The other part of that question, or the other part of the answer to the question, is you have to avoid behaviors that make you burn out. If you find yourself getting tired or depressed, deal with that. Exercise helps. A good diet, of course, sleeping appropriately, avoiding substances, trying to find the things in your life that bring you stress and try to deal with them. The word is called mitigate, which is, of course, to prevent something from happening. I'll let you go on with one last. How did you learn to interact with the parents of patients? Did that just come naturally, or was that developmental over time? Was it you having your own family that says, oh my goodness, I'm a parent now? How did you learn that?
Wow, that's a fascinating question. And I would probably have to ask a colleague how, because, it does occur and develop over time. I think one of the things is I watched other doctors that I admired, how they interacted with patients, how, you learn by example, right? So I could very well learn how to do a lumbar puncture from a colleague or from a mentor, from another resident, but I also can learn how to talk to a family, how to, more importantly, listen to a family, how to encourage, how to engage. And then there are a whole bunch of other books on how to gain alliance with families quickly. And they talk about finding a commonality, kind of figuring out what's important to your patient's mom or dad, figuring out what they want to, talk about first, and listen, and then gain alliance so that when you do have to tell them, oh, we're going to have to do a blood count and that requires a poke in the skin, to be able to gain their trust. And hopefully they'll say, okay, yeah, you can do a spinal tap on my 7-day-old baby because I trust you. And so it's gaining that trust, I think is really important, and it's learning from other people.
This question has come up multiple times, and you may have already covered it. Please forgive if you already did. How did you get that quarter out of that kid?
Oh, that's a great idea. Actually, we used to, okay, this is about 10 years ago, take them out ourselves. We would put the child on a bed, bundle him up, lie him, oh, sorry, you can't see me, on his left side. We would put a tube called a Foley catheter into their mouth, and it push it so that it would go past the quarter. And then with the Foley catheter, you blow up a balloon, and then you pull the Foley out, and the balloon's open, right? And expanded like a bubble, and it pulls out the quarter. It usually comes out into the mouth, and you can get that. But we found over time that sometimes kids nowadays will swallow more than just a quarter. They may swallow two. Remember, I told you they're slot machines. So they may take 1 or 2 quarters, or a penny and a quarter. A lot of other times, kids may try to eat batteries. And batteries, you can tell on X-ray if it's a battery or not, but some batteries, it's a little difficult. And batteries, when they're in the esophagus, are an emergency. And so what we do now is, instead of taking out the quarters of the batteries ourselves, we call a surgeon or a gastroenterologist. So these are specialists who take care of children within the field of, say, surgery, general surgery, or gastroenterology. And they take them to the operating room, put them to sleep, and then they open their mouth and put in these special tubes that have pinchers at the end, and they pull out the quarter or battery under general anesthesia. So that's how we do it now.
There was also the risk, I remember, I've been around forever too, that we would put the Foley in past the coin, pull the coin out, and it would go back in the airway. And we had that secondary problem that it could re-obstruct the airway or make things worse. Thank goodness for pediatric gastroenterologists. Yes. Emma, I know it doesn't seem like an hour, but we've already been talking an hour, and I want you to keep on talking with this wonderful talk that you're doing. Please go on.
We can do it, guys. Okay, so what can you guys do now? Get involved, participate in research. I know it's hard to do, to go into a hospital because of COVID, but you can do a lot of research online because of the electronic medical record. Volunteer. Maybe you don't have to go in to volunteer at a hospital because of dangers there, but maybe you can go and volunteer at a senior citizen's home, or you can go volunteer at some other venue, like at a food fair or at the food pantry. There's lots of opportunity to show that you have a servant's heart. Think about other healthcare related activities that you can do, like even raising funds for the children's hospital, or collecting blankets for the winter when kids come in, and sometimes they come in after accidents and they don't have blankets. Okay, you can do a coat fund. I mean, there's a whole bunch of things that you can do. They're all volunteer, and they're all healthcare related because you're giving it to a hospital. Shadow physicians. Right now, I know that's really hard, but as COVID starts loosening up, you might be able to shadow different physicians. It's important to do. And this program, amazing. You do this virtual shadowing. That counts. That's healthcare related. Get a job as a scribe. That's a way to get into the hospital or get into a clinic and get one-on-one mentoring and exposure to patient care. Some people have been asking about doing post-bac or master's program. Absolutely. If you it's great because you can mature that way. You can learn new things, and you can learn anatomy, right? In your post-bac class, in your master's program. And that'll make first year medical school a lot easier. Bottom line is, get involved by helping others. Be intentional about that. Think about how you can give yourself to help somebody else, because that's your whole career, is all about helping other people. We've done a lot of these questions, but one of them is mentoring. Do I have a mentor? Did I need a mentor? When I was going through college and all that and medical school, no, I did not have a mentor. But once all you need to do is find your friends, find your virtual friends online here, help each other out, because medicine is all about teamwork. You can't do it alone. And it's all about collaboration. And I'm telling you, that is something that we look for in students who want to go into medical school, who want to be a pediatrician, who want to do emergency medicine. We look for the collaborative spirit and people who want to support each other. All right, so what do you think? This is a 2-year-old who's sitting in brother's room and he's eating. He goes, Mommy, I found candy. And they're all stuck together, and we get an x-ray, and they have strung around in the baby's belly. This is not candy, right? Everybody know what these are? Really, really, really powerful magnets. And it's like, okay, it's not toxic, right? These things don't melt and give you lead toxicity. No, but what can happen if 2 magnets are in different parts of the intestine? Say you swallow one and then 10 minutes later you swallow another one. Anybody know? Yep, I see. You guys know they start going, doop, 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 and they loop up. And in between the magnet could be intestinal wall or bowel wall. And with time, with pressure, those magnets squishing each other together, you can get a perforation of the bowel wall, or we call that intestinal perforation, and stuff that should be inside your gut all of a sudden leaks into the outside of your tummy. And that can cause severe illness and injury. Intestinal perforation is not a good thing, and they need a surgeon. Stat. All right, here's another case. Case 3, a 4-week-old infant. He was found unresponsive by mom when she arrived home from work. Mom works nights and her boyfriend watches the baby for her. This is a true story. And the baby was not breathing right, so mom called 911. EMS arrived and they started CPR, and the baby gets to the ED with no heartbeat, no respiratory drive, and we immediately take over CPR. Oh my gosh, this is my day every day. Who's going to tell me what happened? Who do you think? Baby can't talk. Mom is not there yet. EMS can give me what they understand and know, but I need a history. So I'm going to try to figure out, okay, this baby looks like a full-term baby. He's 4 weeks old. What am I going to do? I can't get any underlying history. I don't know his birth history. But mom shows up. And she says that her boyfriend said the baby rolled off the bed last night. And the baby was fine. He took a bottle. Mom went to work. Later on, she finds out the baby vomited, but he slept just fine. He's otherwise healthy without any medical problems. But why does he look like this? Why did he need CPR? And a 4-week-old developmentally, can this really happen? So as a pediatrician, as emergency medicine, I need to know my developmental piece, because I need to know, can this really happen, or did something else happen to the baby that somebody's not telling me about? So while continuing CPR, we examine the baby, and we have to determine the priorities of resuscitation. The priorities of resuscitation, it's easy. A, B, C, airway, breathing, circulation. We're going to breathe for the baby. We're going to make sure that the heart's beating. If it's not, we're doing CPR, and we're going to give medications to start that heartbeat up. We're going to put monitors on it so I know if I'm getting better. I'm going to have to get IV access. And then I'm going to expose the baby and look to see if there's anything else wrong. So here I use my PALS algorithm. Luckily, everything is very systematic. We do airway, breathing, circulation. I start CPR. Well, how do I know how much medication to give? I can't give the same like an adult, 1 amp, right? With children, everything's weight-based. Well, how am I going to know how much the baby weighs? I can guess, or we use this tape called the Broslow tape. And it's like a measuring tape for babies. We lay it out next to the baby, and we can measure the baby, and it gives me an estimate of how many kilos the baby weighs. And now I can determine what medications I need to give. And so it's very nice. We have these special cards. I look at them a lot of times. If you do it long enough, you're going to memorize these things. This is not on your test today, guys. It is just an example. This is something I use when I'm resuscitating a baby or trying to figure out what size or how much medication I need to give, telling my team what type of equipment to get out for that baby. And it's very convenient in emergency departments that take care of mostly adults, because it's hard to memorize all these things, because you can see from a newborn baby up to a large child, things change, right? Their size changes. After exposing the baby, we notice bruises to the abdomen and face. And despite giving adequate CPR, we follow all the rules, we never get a pulse back, and the baby never regains signs of life. Pastoral care and social work comfort the mom and prepare her heart for the next step. We know that anytime we have an unexplained death in children, a medical examiner is consulted to determine cause of death. And for us, with the inconsistent history, we see signs of trauma on the baby. So those bruises to the face and abdomen in a 4-week-old baby shouldn't happen. Developmentally, babies cannot roll off of a bed at 4 weeks. I suspect child abuse. Well, it's important then to know what are the differences between the baby and an adult. And this is a baby, look at his big head. The head is proportionately larger, and thus they're more prone to injury. They also have higher metabolic needs, oxygen needs, calorie needs. They breathe faster. And instead of using their chest wall like we do to breathe, they use the diaphragm, which is a muscle that's right underneath the kind of the breastbone there. It's the primary muscle used for breathing. Until puberty, the bones are soft and they're more easily to be bent or broken. The muscles, they lack tone and power. They can't coordinate themselves. They cannot protect themselves. The other thing to know is that their body surface area is larger compared to their weight. So when you expose a baby and you're doing CPR on them, they're more likely to become hypothermic or have low temperature. Their tongue is really big compared to their little nose and their little mouth. And so a lot of, that's why they're always drooling. Their tongue's big. So what that means is they're more likely to obstruct or have difficulty breathing if there's something obstructing or blocking their nose or mouth. Their trachea is short. And so again, when we're intubating them, these are things that we have to worry about. And you have to also know that their heart beats faster. When the younger you are, the faster your heart beats, as until you get to be an adolescent and an adult, kind of all then normalizes. And then their tummy, soft and pudgy. And so it doesn't protect them, doesn't protect their liver, their spleen. And so if they get hit there, they're more likely to bleed or have what we call, you can even fracture your spleen or your liver. Children are definitely not little adults. So as you can see, physically, they're different. Their growth and development constantly changing. Emotionally and socially, intellectually, they're growing. And so you have to be able to know how these changes occur over their little lifespan. So as pediatricians, it's important to have characteristics of patients, to be understanding, to be a good listener, to be empathetic. We talked about this before, because you're treating both the patient and the parent. Here, you don't have to memorize this, but know that vital signs change with age, and their heart rate is faster when they're lower, and their baseline slows as you grow older until your adolescent years. And then it ranges normally between 60 and 100. Same with blood pressure and your respiratory rate. Things change as you mature physically. So we take care of lots of different things. We're a trauma center. And so I take care of major trauma, as you saw in the beginning. We work as a team. It's a team sport. Nobody does it alone. We depend on each other to be able to, and this is one of those things that you never forget, right? Is when you have a child that's dying because of severe injuries. Sometimes they could have been prevented using car seats or using common sense or not driving and drinking. simple things that sometimes we as parents forget. But that's why we're here in the emergency department, to be able to help. We also have cool gadgets that we use. This is an example of when a little boy came in. And what the doctor's doing is, instead of using needle and thread to suture a cut on his face called a laceration, we use Dermabond, which is glue, and it doesn't hurt. And see how he's just hanging out, drinking water with a straw with his mom. This is what pediatric emergency medicine is. This is a relatively healthy child, but the mom's super scared. And so she's holding the child so that we can Dermabond it safely. It doesn't even hurt. Well, how do you become a great doctor? You have to study hard. Okay, you guys, study hard, learn what you can, develop those study habits. Then we also practice, and this is called simulation. And as AI develops and as simulation improves over the next 10 years, we're going to see amazing things. I'm in Singapore. I know we have a friend online who's from Singapore. Y'all have one of the best simulation hospitals that I got to see, where you actually, your simulation dolls look like real people and they feel like real people. But this is just a plastic mannequin that has a heartbeat, that you can do CPR on, that cries, that opens its eyes, that you can intubate and put on life support. And so we practice really, really hard. We also learn special techniques. And this is called an interosseous line. So here we're doing CPR, like we were doing for our little baby. We're breathing for him with a bag and oxygen. We're doing chest compressions here. We have algorithms that tell us how fast and how hard. We give medication like per the PALS algorithm, but we don't have a way to do that in some of these babies. And so we use this thing called an interosseous or IO drill. It's really just a drill that we can drill a life-saving piece of, it's like a little catheter, so that we can give life-saving medications through this IO. And this is where we give the medications through, and then we continue CPR. The other thing is, last week, y'all asked about what's the difference between clinical and academic emergency medicine. And for academics, this is what I chose. We have what we call the triple threat, which means the best of all worlds, right? The three worlds. I get to take care of patients in the clinical arena. That really makes me happy. I get to teach the next generation of medical students and residents and fellows. So much fun. And then I get to do research, and I do what we call clinical research, where my laboratory is an emergency department. My patients help me try to figure out how to take care of them the best way possible. And I collaborate with Dr. Fowler and his team in emergency medicine, and we try to figure out what the best medications to use, how to administer CPR, how to do the best CT scans, or what type of CT scans to order. And we do all this research collaboratively together. And I work with all these people here, residents, scientists, researchers. And then for me, I needed to balance my career and my family. And so you need to, and nobody can tell you the right formula, y'all. Y'all have to decide what is important to me, what will make me happy. And I needed to have, I wanted children. I needed to be realistic on how to raise these kids. And so I needed to ask for help and to be okay to ask for help. I had a partner, my husband, who really was supportive, and he chose to help me so that I can do things in my career that otherwise without him, I wouldn't be able to do. He did a lot of the cooking. He did a lot of the chores. But I also asked for other help. I had to ask people to help me clean my house and to do the laundry. And it's okay. It was okay. I couldn't do everything. I also had to know that if something wasn't working, it was okay to change my mind and to be okay with that. And I had to love what I was doing, because medicine is a life of sacrifice, you guys. And so you have to really love serving others, love taking care of your patients, and love giving sacrificially. And you might not be able to go out to the movies with your friends. You might not be able to go out to dinner. You might have to work, and to be okay with that because you love your job. So I'm gonna kind of ask Lindsay Zhang, she's listening online, to give you guys some suggestions and some things, helpful hints that she thought were helpful for her as she was preparing for medical school. She's currently a second-year medical student, and it was a long haul for her too. And Lindsay, let me just open it up 2 minutes for you.
Hi, everyone. Thank you, Dr. Okada, for letting me speak very quickly just about my journey into medical school. As Dr. Okada said, my name is Lindsay Zhang. I am a second-year medical student here at Tulane University in New Orleans, Louisiana. And yeah, my trip to medical school was difficult. I knew I wanted to be a doctor from a long time ago, but that just proved that the journey would be long. After graduating from USC in Los Angeles, I took a gap year to say, and got my master's, medical sciences. And that really was great for me. That prepared me very well for medical school, and that I had a whole year of really digging into the medical sciences, learning and honing in my study skills, learning how to use different study resources and how to stay focused, and how to really put myself to the grind and prepare for what medical school would be like. Because yeah, every day it's just studying. Of course, you get a lot of opportunities to volunteer, to stretch your creative bones. I'm a part of a group called MedArt, in which we connect students, medical students, with the community through art volunteer and whatnot. But a lot of it is studying, and I had to spend a lot of time. I spend most of my day just sitting right here at my desk studying. And so I think that's something that people expect, but they also don't quite realize how taxing that can be. So my gap year in the master's program was pivotal for me to really get that under my belt and be able to study well and efficiently. I see a lot of people asking about study tips. I mean, you can Google so many. There are a lot of study tips, but my number one study tip is, well, number one is do it. Actually do it. Sit down. Use whatever like timer or Pomodoro method or friends to keep you accountable, but sit down and do it. As well as practice. Use a lot of practice questions. Those are my two favorite study tips. So best of luck, everyone. You can do it. Thank you, Dr. Okada.
Thank you. Thank you for sharing. I know it was a long journey for you, and I know I'm just looking at the chat, finding that it's been a long journey for a lot of y'all, but you can do it. Just keep chasing after your dreams. Find somebody to support you, to be your cheerleader. And that's what these groups are really pivotal in doing, is making it so that you can get there. Because you know what? I depend on you guys to take up the helm and to be the next generation, to take care of all those children that are out there. You guys are really, really, really important, whether you're going to PA school, medical school, whatever your desire is to be in healthcare, please just keep trying. Now, I'm here to answer any questions that you guys may have.
Pam, why are you going for a business degree now? I mean, are you ever going to get out of school?
So that's a good question. So one of the things that I think is really important, you guys, as you go into healthcare, you're so focused on medicine, right? I'm so one-dimensional. I know medicine, or I have to study it, but it's like a second language. But business is hard, and now in this climate, you're gonna need, if you want to open up your own practice, or if you want to be able to help make good financial decisions for your practice partners or the institution you work for, you kind of need to have a little business background. And so I'm learning about things in my MBA at UTD that I have never heard about before. Organizational leadership, how to deal with conflict, and all these different things that nobody's ever taught me. And so it's been fun.
What are you working on now in research, Pam? You have a specific topic?
I just finished a large randomized trial with children after having the grand mal seizures called status epilepticus. A lot of the medications, okay, you guys, this blew my mind. A lot of the medications that we use have never been tested, or the dosing and the risks and benefits have never actually been tested in children. They've all just been kind of extrapolated from adult use, from adults. And again, remember I told you children are not little adults. And so now we're finding out that maybe the medications that we're using might not be the right doses, or might have some side effects that we really didn't think about in little children. And so that's my job. I'm studying these, what we call orphan drugs, that haven't been studied in critical situations. And so I'm studying seizures and status epilepticus. Oh, and I'm also, remember we talked about the simulation? Well, with COVID, when we do CPR with children, are we spewing COVID all over everybody? And should we be using protective barriers? And so I'm working on a study where we're using simulation and COVID particles to see if, pretend COVID particles, just colored molecules, and to see if we can prevent the spread while we're doing CPR.
So Pam, what's going to happen with the kids going back to school and COVID? Do you have an opinion?
We do not know what's going to happen. We don't. And we all had a Department of Pediatrics meeting, and that's the big question. Only time will tell. We just need to be flexible and ready to meet their needs.
COVID is such an odd new disease. We've seen coronaviruses before, but never on a scale of this magnitude. And there's a 100-year-old plus term called inoculum, which is exactly how many of the bugs do you get into you. And it may be about COVID that if there's only a tiny inoculum, a tiny number of bugs you get into, maybe you don't get disease. And maybe it has to do with the amount of the bug that you get into you. That it depends on whether or not you get sick at all.
Fascinating.
Pam, I can't imagine with someone such a gracious angel as yourself that this question could be relevant, but this came up. Did you ever have a low point? And if so, how did you overcome it along the way?
Okay, so who asked me that question? I like that question.
Speak up, whoever asked that question about the low point. They're here somewhere.
I love that question. So about 15, 16 years ago, I was, it was more than that. Sorry, I lied. 20 years ago, I was pregnant with my fifth kid, right? And I was working full time, working really hard. And my oldest daughter she was in third grade at that time. She started growing up and having headaches and falling. And I'm like, what's going on with her? Am I being all paranoid? Maybe there's something wrong. Maybe I better take her to the doctor. Long story short, she was diagnosed with a brain tumor. And
with
so
what,
now,
please?
A brain tumor.
Oh.
My oldest daughter had a brain tumor. And now I'm faced with, I'm working, my daughter has a brain tumor, I'm pregnant. What am I going to do? And that was a really low point. I couldn't do it all. And I had to be okay with not being able to do it all. And so with my job, the flexibility of my job and the support of my bosses, I went part-time. And so I went to 65% time, and I took care of my daughter, who, by the way, is amazing and did fine. And she's also in medical school. And because of the support I had from my colleagues and my friends, my family, and my church, I was able to get through that really, really difficult time.
What an astonishing story, Pam. So did you have to get used to dealing with kids that could be really brats and combative sometimes? Or do you just love them out of it, or you hold them, or how do you deal with it? Say a combative, difficult to deal with child?
You got to think like a child. Think, why is this child acting like this? Is he afraid? Most of the time, they're afraid. They don't know how to verbalize what they're feeling. And so you just sit on the ground, or you just sit and be patient and wait, or distract them with something fun, and you gain alliance with a child. And so you have to think like a child. It's fun.
Pam, did you really have ADHD or were you just being funny?
No, so I've mellowed out a lot, and I've married to a guy who definitely had ADHD growing up. And so it's one of those things where you just have to learn to focus. And they didn't have this diagnosis 25, 30, 40 years ago, right? It's all relatively new with all the learning disabilities and difficulties that students are experiencing now. But I highly recommend, do not let those disabilities or those names or those diagnoses tag you. No, you can overcome anything. You just figure out how you figure out your study habits. You figure out what, like for me, if I drank coffee, totally helped. I didn't know that. I was drinking like 4, 5, 7 cups of coffee a day. Really helped me. So you just figure out how to manage it, and you don't let anything define you. You just go for your dreams.
All right, Pam, so I'm sitting in Douglasville, Georgia, about a half an hour west of Atlanta, my hometown. Was born here. My father was born here. My grandfather came here over 100 years ago. In 1956, at the age of 4, I was held down screaming to get the Salk vaccine for polio. There was a horrible polio epidemic in the world, but in America. And my father and mother took me right to that old hospital, held me down screaming like a combative brat, and I got the shot. We all know that there's been an astonishing impact on human populations. It was 1928 that Fleming et al. Discovered that antibiotics could change the course of bacterial infections in humans. But there's been vast amounts of resistance to antibiotics. And what has made such an astonishing difference in public health is the availability of vaccines for a host of medical problems. It's odd that between terrible epidemics, we see a thing, and I say odd because I'm not being judgmental, about some parents not wanting their children to have vaccinations. I really don't want to use the term anti-vax because I think that's categorizing. But for parents who feel like that they've gotten themselves informed and they choose not to vaccinate their children, what's your approach on that? You take an I am the right person, it's my opinion that's correct, listen to me, or what do you do about
that? So for the parents who choose to not vaccinate their children, that is their choice. And that's how, from an emergency medicine standpoint, we don't judge. We just want to help the child, right? Because it's not their choice, it's their parents' choice of how they're going to take care of their little one. So what my job is to gain alliance with the family and to know what the best next steps are for that child in the emergency department. With kids who come with a fever who've never been vaccinated, I know that they're at risk for other bacterial infections like Haemophilus influenza. And so I'm going to be what we call a little bit more conservative in the treatment care plan. I'm going to do more tests, and I'm going to give antibiotics through an IV if the families allow me to. If they don't, a lot of our families have pediatricians that they have trust relationships with. And so I'll call a pediatrician to help them help me take care of their patient family dyad. So it's really about gaining alliance to figure out what is the best thing for the child. How do I help the family understand in that moment how to take care of that child? And then they can go back and talk with their pediatricians about vaccinations, and it's their choice, really.
Pam, okay, thank you. What a wonderful answer. It's a partnership, after all, that we enter into gaining an applied science so that we can partner with patients to help everyone improve. Pam, as a child gets older and more aware of the medical process, how do you integrate the parents' decision-making with the child's developing autonomy? Perhaps maybe even when the parents could be overprotective.
And that's hard. The overprotective parent is hard. Sometimes, well, especially if you're dealing with say a 16-year-old or an 18-year-old who comes to the emergency department because they have a question, but they don't really want to ask in front of their parents. And so we have a process in the emergency department where we will ask politely to the child, would you like your parent to stay, or can they go get some coffee while we just have a little talk? And then that allows the parent to go take a break. And then I can talk with the student, the patient who's 16, 17, 18, who might have some very private health questions that they want to talk about. And it's it's separating the child from the parent.
So Pam, rumor has it you're kind of opinionated about the admissions process to medical schools. You have some experience in that area. Do you think a gap year is a good idea for kids after college? Take a year off and do something? Should they just hang out and eat French fries, or should they? What do you think about a gap year?
French fries and a master's program always go well together. So I think it's really, every student is different. And if you feel like you want to boost your application with, say, more life experience, then go for it. Go take a gap year and do something, though, really intentional. Don't take just to take time off and to travel. That doesn't bode you well, but do something that's in line with your end goals. So if your end goal is to get into PA school, do something that will get you into PA school. Shadow or scribe, okay? Because those clinical hours, those hours that you do helping others and observing will help you get into PA school. If it's for medical school, do something that's in line with getting into medical school. So if you decide to take a year off to scribe, I'm telling you, our scribes who apply for medical school and then end up in pediatrics, they do really well because they already know the flow of a patient history and physical exam. They blow people out of the water. So scribing is a nice job to have. A master's program is great because you learn your anatomy, makes so that you can do really well your first year.
We've gotten this question a couple of times about children with special needs and who may have mental and physical disabilities. Did you as a doc receive specific training in working with children with mental and physical disabilities?
That's an excellent question. We, in residency, you do get training, not a lot, maybe 1 or 2 rotations where we'll do specialty clinic in autism, neurology. We have special needs children. We also have complex care rotations where you take care of children with, say, tracheostomy, G-tube, seizure disorder, wheelchair bound. So we do get training during your pediatric residency.
I think you've already answered 40 questions for us, Pam, and we've been going an hour and a half. What an astonishing discussion. This has just been so wonderful, especially your charm and your ability to bring to bear what your long experience has been, your path that you got there, how you've managed a family along the way. I just want to say, let's get everybody on chat to give a shout out to Dr. Pam Okada, who has just been a blessed person to come be with us. We just love you to death. Do you have anything, maybe some closing thoughts for the group, Pam?
Really, I want to encourage all of you guys, I don't know how many people are online, but I want to encourage you guys all to just keep going, keep the faith. You can do it, study hard. Everybody's path is not the same, okay? And that creative difference makes you stand out, makes you better. So just keep going, especially during this hard COVID time. Just rally around friends virtually, encourage each other.
There are over 1,000 people with boiling thank yous coming out on the chat. So we just want to thank you so much, Pam. These are special sessions for us. This is our 11th. It's so wonderful to be able to cap off special session like this. We're going to keep going, folks, out there in virtual shadowing land as long as you keep coming. The GroupFundMe thing was a thing where we wanted to try to make this project pay for itself, though it's not been terribly expensive. So do think about it. We'll send out another GroupFundMe notice. We'll be back next week with a trauma surgeon who is at the University of Chicago, formerly at Parkland. Dr. Brian Williams was the chief of trauma who was on the terrible day when the policemen were assassinated, those 5 policemen were assassinated in Dallas. And so I think you'll find an astonishing lecture from him. And then following that, Dr. Angela Gardner, past president of the American College of Emergency Physicians, one of the finest doctors I've ever known, and a business person in her own right, will be talking about physicians and finance and the money you're borrowing to go to school and how this will all play later. So the next couple of sessions are going to be just absolutely terrific. We put out there the Quest-based exam. I'll have it posted for you in about a half an hour to an hour out on the website. Once again, thank you to the working group for the virtual shadowing sessions. And Pam, once again, thank you so much. And to everyone, we bid you a good evening.
Bye.
Hi, thanks.
Bye, Rachel.